My name is Diane Kwan. I'm one of the general and bariatric surgeons here at John Muir. And Rebecca asked me to talk about obesity and surgical risk. So first, no obesity talk is complete without the statistics and talking about BMI. So BMI, or body mass index, which I'm sure everyone in this room knows about, is weight in kilograms divided by height in meters squared. And that gives us a very nice, easy, objective number to take a look at when we're seeing patients. A normal weight is a BMI between 18 and 24. And then a BMI of 25 to 29 is considered overweight. And then once you hit 30, that patient's considered obese. There are different categories of obesity, of course. There's class 1 obesity, which is once you hit a BMI of 30. Then it goes up by increments of 5. So class 2 obesity, or morbid obesity, is when you hit a BMI of 35, and then severe obesity when you hit a BMI of 40. So the CDC, every year, they do a survey to assess and estimate the prevalence of obesity in the U.S., and you can see in 1991, the majority of the states are in that light blue color. So the adult prevalence of obesity in those states is between 10 and 14%. If you fast forward 20 years to 2015, you can see that that number has drastically changed. So they changed their color coding, but basically more than 35% of U.S. adults are obese. You can see that 21 states fall into this orange color, which means 30 to 35 of that adult population is obese. 19 states fall into the yellow color, which is a 25 to 30% prevalence of obesity. And actually 4 states are creeping in at over 35%. So that's Louisiana, Mississippi, Alabama, and West Virginia. So it's pretty impressive. In addition, that's just obesity. So almost 70% of U.S. adults are overweight or obese, so above a BMI of 25, and about 6% have extreme obesity, BMI of over 40. Some other interesting things that's different between different groups. So non-Hispanic Blacks have the highest prevalence at 48%, Hispanics at 42%, and then much lower for non-Hispanic Asians at about 11 or 12%. And also by different age groups, so middle-aged adults are the most affected. Age 40 to 59 have a prevalence of 40% of obesity, followed by older adults over 60 at 37%, but even young adults between the ages of 20 and 39 have a prevalence of 32% of obesity. And these are just some interesting facts with having to do with gender and socioeconomic status. So men with higher incomes are more likely to have obesity, whereas women with higher incomes are less likely. And also with education, women with higher level degrees are less likely to have obesity, whereas for men there's no relationship. So with all of that, those data and facts, we can no longer kind of ignore the issue. There is a global epidemic. And these pictures are not meant to be offensive or mean, but these are actually patients that I see in my office, and not even in my bariatric clinics, in my general surgery clinics as well. Most of my patients, I would say, fall into the overweight or class 1 obesity category, and so these are significant issues we have to talk about before we deal with surgery. So there's a strong impact of obesity. There's still the social implications, right? So obviously it's a big form of social discrimination, and I get that in clinics too. So they come for bariatrics, they're obviously ready to talk about their weight and what to do about it. But when they come for general surgery, sometimes we have to address the topic, and they're not really always expecting it, but they have always thought about this. They've been on multiple diets, and they've tried many things, and they do feel guilty. So they know it's an issue. There are the economic implications. So the personal cost, people can spend up to $15,000 per year in diet, food, and other medications. And then, of course, the national health care costs. So the U.S. Spends up to $200 billion annually in medical costs related to obesity. And of course, we know this, the medical and health implications. So there's a significant increase in coronary artery disease, stroke, a huge increase in diabetes, and then of course that translates into an increased mortality risk as well. So while the U.S. is leading the pack, we are not alone. Many other countries are following closely behind us with the obesity epidemic. So obesity poses unique challenges to surgery. You know, when I see a surgery patient who is obese, we think about many different things. So what kind of surgery are they having? Is it emergent or is it elective? Elective surgery obviously gives us the time to be able to prepare and optimize things medically before we do it. And then what kind of surgery? If we're removing a 2-centimeter lipoma, that's an office procedure and it really is very low risk. So we're not thinking about too much. But, you know, if we're doing a ventral hernia repair in an obese diabetic patient, that's a completely different story. You know, does it require general anesthesia? Is this something we should be doing at the surgery center versus the main hospital? So if I have a healthy 20-year-old who has a BMI of 40, I would still do that at the surgery center. But if we have a 50-year-old with a BMI of 60, that's obviously going to be at the main hospital because they may have to stay afterwards. We may need pulmonology consults and things like that. So obesity increases the risk of wound complications, thromboembolic events, and respiratory depression with, you know, sleep apnea and things like that. So those are three of the big things that I think about first. And so to optimize patients, we obviously try to optimize their diabetes, any sleep apnea, and the DVT prophylaxis. And then, of course, cardiac history as well. But for a surgeon, that's fairly straightforward. If they have a cardiac history, if they have a cardiologist, we kind of send them over to cardiology. So diabetes, there's a well-known link with diabetes and surgery for increased complications. So this study is from Diabetes Care in March of 2014, and they looked at the patient data registry at Brigham and Women's and data from the NSQIP database as well. And they looked at all patients who were admitted to the hospital for over 1 day and stayed after non-cardiac surgery over a 5-year period. They found over 600 patients who had a hemoglobin A1C value within the last 3 months, and then divided those patients into 4 groups. So hemoglobin A1C of less than 6.5, between 6.5 and 8, between 8 to 10, and then over 10. And they matched these patients for age, gender, and BMI to non-diabetic control. And they found that hemoglobin of A1C of 6.5 to 8 had a similar hospital length of stay to the control group, whereas chronic hyperglycemia with a hemoglobin of over 8 is associated with poorer surgical outcomes based on a longer hospital stay. The number of meaningful events for death, infections, and readmissions were too small for them to meaningfully evaluate. But they did say they also found lower hemoglobin A1C lower than 6.5 was also associated with an increased length of stay, but that's unclear because these patients had higher rates of hypoglycemia and things like that. So I won't go too much into diabetes because I think Dr. Kalamas talked a few weeks ago just about, you know, pre-op issues with this, but there's evidence throughout, you know, our literature and cardiac literature, ortho literature that diabetes is associated with increased infections and post-op complications. So what we typically do for that, you know, as a general surgeon, we worry about wound infections, wound complications. So infection, dehiscence, mesh complications, especially if we're fixing hernias and placing mesh. And what we like to see is a hemoglobin A1C of less than 8.0 for elective surgery, elective general surgery, I should say. And then for bariatrics, since these patients are obviously at higher risk, we give them a little leeway and ask them to be under 8.5. And obviously the PCPs and endocrinologists help us with this. So sleep apnea is a big issue in the obese population as well. In the general population, the prevalence of moderate to severe sleep apnea is 10 to 20%, and the majority of those patients remain undiagnosed. In morbidly obese patients, that number is way higher. So for patients with a BMI of over 40, that prevalence is about 70%, and then over 60, it's 90%. So, I mean, you can pretty much expect it in a patient with a BMI of 60. So why that matters is there are known increased complications after surgery with untreated and undiagnosed sleep apnea. So post-op delirium is reported to be 53% with sleep apnea patients after surgery, whereas it's only 20% in patients without sleep apnea. Hospital length of stay is longer. Sleep apnea patients tend to use more ventilatory support, telemetry services, and other hospital resources. And after surgery, patients with untreated sleep apnea have a much higher risk of being transferred to the ICU for care. And of course, there's 2 times the risk of pulmonary complications such as pneumonia or respiratory failure, and then twice the risk of cardiac complications such as MI or arrhythmias and hypertension. And the depression of breathing is usually within the first 24 hours when they're kind of recovering from all the anesthesia they've gotten and they're getting a lot of narcotics. So there's various ways to treat sleep apnea, but we pretty much focus on the CPAP. And in our office, we have all of the bariatric patients who are diagnosed with sleep apnea. We don't have them fill out this questionnaire. They just bring their mask to the hospital with their home settings, and they use the hospital CPAP machine. But every patient who comes in for a bariatric consult without the diagnosis fills out the Stop Bang questionnaire. I'm sure you're all familiar with that. But basically, Stop Bang is the acronym for all the questions you're supposed to ask them. You know, so S for snoring. Does your partner wake you up at night because you're snoring too loud? Daytime tiredness. Has anyone observed you stop breathing in the middle of the night? Pressure for high blood pressure. BMI for BMI over 35. Age older than 50. Neck size and gender. So male, if you're a male gender, that gives you an increased risk. So then you tabulate all these points, and basically if you're a moderate to high risk of having sleep apnea, then we send you off for a sleep study and to the pulmonologist for CPAP machine. And ideally, we like to have patients on that for 4 weeks before we do any kind of elective surgery. So thromboembolic events, of course, obese patients are at risk, increased risk for that. Basically, anyone undergoing surgery is at risk, and then any obese patient is at risk. So we do chemical, mechanical, prophylaxis and early ambulation. If there's anything unusual, any kind of, factor deficiencies, then we really get them off to hematology. This is a thrombosis risk factor assessment. This is from the ACCP or the American College of Chest Physicians. They print out the guidelines for DVT prophylaxis, and it lists all the risk factors in here and assesses, points to these risk factors depending how severe they are. So you can see that obesity alone gives you 1 point, and then any kind of surgery that's laparoscopic or major over 45 minutes gives you 2 points. So you're already at 3 points, which makes you a higher risk. And then they recommend compression devices and chemical prophylaxis with heparin or Lovenox. So that's almost all our obese patients having any kind of major surgery. With the bariatric patients, we do actually go an extra step and we give them a pre-op dose of heparin once they're asleep, and that's based on our society guidelines. So now to the fun part, the intra-op considerations. So obviously you can tell these patients are going to be more difficult to intubate by the anesthesiologist. They have large tongues and sometimes small jaws and a lot of weight on them. Then even once they get intubated, it is difficult to ventilate them because of all the weight of the abdomen on the lungs. So a lot of the surgeries we do, like the gallbladder surgeries, the foregut surgeries, or the bariatric surgeries, we luckily are able to help the anesthesiologist by putting them in reverse Trendelenburg, with head-up position, and that drops all that weight down and helps them quite a bit. If we're doing a colon or something in the pelvis, then we actually just communicate well with the anesthesiologist as we're placing them head down, and there's a limit there, so how much they can ventilate. So positioning is always a consideration. Table weight maximum, we don't usually have these issues at John Muir, especially at Concord, because it is a bariatric center, so our table weights go up to 1,000 pounds. But for a smaller hospital or something like that, this would be a consideration. You don't know if the patient is, will fit on the table. You need to stabilize these patients. We have new pads that kind of, really nice foam pads that keep them there stuck to the table so they're not moving around. But, before we used to have to strap them in 3 places as opposed to a normal weight patient who gets strapped in 1 place, right? So you have the hips, the knees, and the shoulders. And this has never happened to me, but it has happened that obese patients have fallen off the table. It's terrible because you can't just catch them, right? I mean, once their top falls over, the whole body falls over, and then it's an emergency trip to the CT scanner. Doesn't happen often, but, and then, you have to be prepared with moving assistance and all of that. So the technical aspects, I would say, so thickness of the abdominal wall is really important. So we do a lot of laparoscopic surgery, right? So you can imagine that when you place a trocar through the abdominal wall, if it's thin, you have a lot of mobility at that fulcrum. So you can move forward, you can move back, there's not a lot of resistance. But as that abdominal wall gets thicker, it's very hard to, maneuver and keep your fine movement and things like that. And of course, this is true for open surgery as well. I mean, doing a colectomy on someone with an open colectomy on a patient with a very thick abdominal wall is difficult to get good exposure. There's also the issue of intra-abdominal or visceral fat, if you've heard of that term. But basically, it's harder to do the surgery because intra-abdominally the patient has more fat. So on this left side here, this is a thin patient undergoing a sigmoid colectomy. So when you do that surgery, you pick up the sigmoid colon, and essentially the mesentery just hangs there. You can see through it. You can see where the blood vessels are. You can see where the ureter is, and everything's pretty easy. But when you have an obese patient, all of that is much thicker, and it's just not as easy to see. You have to dissect a lot more. You get into more bleeding. And then also, of course, fatty liver, right? So anytime we're lifting up the liver, this is a gallbladder removal. Sometimes we have to move the liver for our foregut surgeries, and that is difficult if the liver is plump and juicy, and you nick it, and it just bleeds a lot easier. So, we're actually not just whiny surgeons. We used to just wake up in the morning and say, oh man, we have to, work on this BMI of 40 colectomy, and it's going to be difficult. So we knew we'd have to eat a big breakfast that day. But they actually did studies that it is technically difficult, and there are outcomes associated with that. So this is from the diseases of colon and rectum in 2008, and they looked at, it's a Japanese study, and they looked at whether visceral obesity is a more useful predictor of surgical outcomes compared to BMI after lap colectomy. And they looked at 133 consecutive patients who underwent elective lap colectomy for sigmoid colon cancer in a 6-year time span. And they measured those patients by visceral fat area. So there's a couple different ways to measure that, CT scans, waist measurements, or you have a special scale that will measure the amount of fat, or by BMI. So I guess in Japan they consider a BMI of over 25 obese, but not here. And anyway, so they found 51% of obese patients according to visceral fat area, and then 20% according to BMI, maybe because the BMI cutoff was lower. But using either definition, obese patients had a significantly longer operative time. And then patients classified as obese by visceral fat area had significantly higher incidence of wound infection and overall complication rates than compared with non-obese patients, where there was no significant difference when classified by BMI. Hospital stay was a little bit longer in the obese patients categorized by visceral fat, and so their conclusion was just that it may be a more useful indicator. Practically speaking, I don't know, not many of us are sitting around calculating visceral fat in the office or sending them off to this. It's more just kind of a mental note that this is going to be more difficult. So I do a lot of robotic surgery, and I see a lot of advantages, but this is not a robotic talk. But I see an advantage especially in the obese surgical population, so the bariatrics and the general surgery patients, because on this left here, that's a standard laparoscopic procedure, meaning you put the ports in and you're dealing with that thick abdominal wall, and you're standing there holding the instruments, which are like long chopsticks. And so when you have that amount of torque with a thick abdominal wall, getting your fine movement at the end of your instruments is very difficult. But when you have the robot actually, kind of eliminates that torque. You can't feel it, and you're able to reach further, and you're able to still control that fine movement at the end of your instruments. So for the bariatric and the obese patients, I feel like this kind of levels the playing field. So if we have BMIs of 50 and 60, I always look on the robot. And these are just the instruments to show you Laparoscopically, they're straight all the way to the tip, but robotically you have wristed instruments at the end. So, you don't have the torque, and also when you're inside, you have wristed instruments. So that's how we do the surgeries. So most patients, if you're doing a gallbladder or other things, we would just, optimize the medical risks and then move forward and do the surgery. There are some patient populations where we ask them to lose weight first. So one of those is ventral hernias. So obesity or increased weight increases the risk of developing hernias. So it increases the rate of hernia recurrence as well. So you can see here on the left, this is a normal weight patient with a 1 to 2 centimeter umbilical hernia. That's a fairly straightforward problem with a low risk of recurrence. So I would even do that open at the surgery center. That's a very different patient from this patient who is obese, has an incisional hernia with bowel in there, could be diabetic, and we are going to definitely put mesh in. So we do encourage these patients to lose weight. And I usually try to get them to a BMI of about 35 before we operate. Some of these patients are good candidates for bariatric surgery first if they're interested and they meet the criteria. And in general, we try to do the sleeve gastrectomy in these patients because you're able to stay all in the upper abdomen. You're only resecting the stomach. And so you actually can avoid the hernia altogether. So I like to do that in a 2-stage procedure. We do the bariatric surgery or have them do medical weight loss, whichever is their preference. They lose the weight, and then we come back and fix the hernia. And the reason we do that is because technically it's much easier to fix a hernia. They have much more laxity in the abdominal wall after they've lost the weight. And also because those 2 surgeries are in separate locations. So sleeve gastrectomy up here, ventral hernia is down here. It's a different approach, and I wouldn't want to increase a hour surgery to a 3 or 4 hour surgery just to do it at the same time because they have increased risk of DVTs and those things. The other group of patients we ask to that are special and need some weight loss consideration are the paraesophageal hernias. So in a normal weight patient, if you have a large symptomatic paraesophageal hernia, we go ahead and just repair the hernia. Their recurrence rate is acceptable, and that's all you really need to do. But if you have an obese patient with a large paraesophageal hernia, fixing the hernia alone would come with a close to 40% recurrence rate. So in those patients, a lot of times we recommend the gastric bypass at the same time as the paraesophageal hernia, unless they're able to lose the weight first themselves. And this is actually done as a 1-stage procedure because you're working, all in the same area on the stomach. And similarly for hiatal hernia or reflux, if we're operating on that in a normal weight patient, innocent fundoplication is the appropriate surgery there. But if you're operating on an obese patient with severe GERD, the main problem is the weight. So we actually recommend, again, a bypass and sometimes a sleeve for that. In our bariatric patients, we routinely ask for some weight loss before surgery, and usually about 10% of your excess weight loss is what we ask for pre-op. So if you have a BMI of 40 patient, that's only about 5 to 10 pounds that they have to lose. If they're super high risk with a BMI of 65 or 70, we ask them to get down to a BMI of 60 before we do surgery. And the goal is, twofold. I mean, one, technically it's easier and all those things we already talked about. But 2, we want to make sure they're able to comply with the lifestyle changes that are necessary before bariatric surgery. And then the third group is not a general surgery group, but orthopedic group. And I think we had an orthopedic surgeon speak earlier this year too, that there's a lot of literature coming out in the orthopedic group that before you do a knee replacement, they actually have better outcomes if they lose the weight first as well. Shorter anesthesia, operative times, and tourniquet times, and decreased wound issues. So again, all of this is elective surgery. If we have emergent surgeries, those are things like sometimes we can't control. If they have renal dysfunction, sometimes we can, manage that right before surgery, and we can always do the DVT prophylaxis. But emergent surgeries, we can only focus on postoperative care. So that's the, undiagnosed sleep apnea. We just have to be aware of limiting narcotics to decrease the risk of respiratory depression. Use CPAP, get pulmonology on board if they're around. And then, treatment of the patient afterwards. Should they go to telemetry? Should they go to the regular floor or the ICU? DVT and prophylaxis remains pretty much the same. If we're not able to control their diabetes beforehand, we just do tight glucose control afterwards and keep them below blood glucose of 180. And then nutritional status always has to be addressed as well, because it's a little bit counterintuitive, but these obese patients frequently can be malnourished and their prealbumin is quite low. So we want to get them nutrition as soon as possible. So, so for surgical risk, are there risk scales? And there are. This is from the Obesity Journal. It's a mortality risk score. And this study was done in the Netherlands, and they took over 2,000 patients undergoing gastric bypass, so this is not the general surgery population, at a single university from 1995 to 2004, and assessed pre-op factors correlating with 90-day mortality in the hospital. So they found 5 independent variables correlating with mortality, and that's BMI over 50, male gender, hypertension, PE risk, and age over 45. That's kind of like most of our patients almost. And then they basically categorize them to low, intermediate, or high risk, which ultimately, again, clinically, I don't know that changes that much either than, most of us aren't sitting here calculating this score, but we know that those are risk factors to talk with the patient that they may have higher than average risk for having gastric bypass surgery. So all of that just, helps us to talk to the patients, select the patients for these surgeries, set them appropriately and discuss their risks, and then treat them afterwards and get them to the appropriate place in the hospital where they'll receive the appropriate level of care. And all that ultimately falls into their outcomes. So. And then after all of that, there are a couple studies now out recently that say obesity is commonly considered a surgical risk factor, but the degree of risk is not been precisely quantified, and that while obesity is associated with all these comorbidities that do increase the risk, obesity itself, we don't know if that alone increases their risk. So this is a study in the Anesthesiology Journal from 2015, and they look at how BMI affects the postoperative complications and long-term survival after surgery. And they looked at over 4,000 patients in a period of 6.3 years and analyzed the impact of body weight on post-op mortality and morbidity, and found that the obese patients did have more concomitant diseases, increased risk of wound infection, greater intra-op blood loss, and longer operative time. But they actually found that being underweight was associated with a higher number of complications. That underweight patients had a worse outcome, whereas being overweight was associated with somewhat of an improved 90-day survival. So their conclusion was that obesity alone is a significant risk factor for wound infection, more surgical blood loss, and longer op time, but that the tendency to regard obesity as a major risk factor for general surgery is not justified. That's it. Any questions?
Yeah. How low does the BMI have to get before you do a knee replacement? Do you have a number? Is it 35 or?
I think it's around 35 for the orthopedic surgeon. Oh, sorry. The question was how low does the BMI have to get for total knee replacement? That's more of an ortho question, but it's around 35.
What is the difference in the magnitude of risk between your bariatric patients and obese patients who are having major cardiac or joint replacement? How much more risk is it for bariatric than the others?
So For bariatric surgery, the mortality risk is actually pretty low. It's about 0.3% on average.
Compared to, say, joint.
So I'm not sure about the mortality of joint replacement, but for cardiac surgery, it's about 3%.
Is there a preferred, what's your preferred method? Maybe I missed it because I stepped out. Are you doing the Roux-en-Y or the gastric sleeve, or do you choose based on the patient?
Yeah, I choose based on the patient. So I do both. Sorry. So the question was, what was my preference for bariatric surgery, gastric bypass versus a sleeve gastrectomy? So I think they're both good procedures. And I know a lot of surgeons are only doing sleeve gastrectomies. I do it on a selective basis. So patients with very severe reflux or Barrett's esophagus, I would not do a sleeve on because it can be refluxogenic. Whereas the bypass is, surgery is actually treatment for reflux. If they have a very strong history of smoking or drug use in the past, even though they have abstained, I might stay away from a gastric bypass because the risk of marginal ulcer is quite high in those patients. So it depends on what the patient wants. If they come and I do the pre-op workup and there's no contraindication to either, I usually listen to what they want, which nowadays is the sleeve. But some people come wanting the bypass, and so yeah, so selective.
Just the criteria for bypass, it could be over 40 with no comorbidities, or?
Yeah, BMI of over 40 with no comorbidities or 35 with one comorbidity. And that's pretty much across the board for all insurance plans. All righty.
Thank you.
Thank you.